Hello there. Welcome to our program, the Digital Anatomic Pathology Academy, Surgical Pathology Digital Sign-Out Slide Review. I'm Dr. Lewis Hossel, coming to you from the University of Oklahoma Health Sciences campus. Our program is part of the Digital Anatomic Pathology Academy, a joint venture between PathPresenter and the Digital Pathology Association. I'll point out that membership in the Digital Pathology Association and access to the digital anatomic pathology resources are complementary to members and complementary to students in training, as well as pathologists in the developing world, low and middle income countries. So let's jump into our case today, which comes from the realm of GI surgical pathology. It's a 60-year-old gentleman who has a history of a lymphoproliferative disorder, a low-grade lymphocytic leukemia, and has now been found to have an anal mass. So that puts him in a slightly immunocompromised setting and certainly raises concern that this mass could be infectious or potentially one of the neoplasms associated with immune modulation. When we think about anal masses in general, obviously, more commonly, we would see things like inflammatory polyps or the solitary rectal ulcer syndrome due to prolapse and so forth, or maybe hemorrhoids, which can produce polypoid masses and so forth. And in an older gentleman like this, perhaps pre-invasive polyps, tubular adenomas, and so forth. Those would be fairly common causes of a mass. When we're thinking about viral-induced tumors, the HPV lesions that can be seen here include things that range from condylomas, including the giant condyloma, or so-called Buschke-Lowenstein tumor, as well as adeno and squamous carcinomas. Now, other tumors like melanoma do occur here, as well as some stromal neoplasms, and occasionally you'll get metastases to this location. Could this be a primary leukemic infiltrate? Certainly that's possible, but relatively uncommon, even in those patients who have a lymphoproliferative disease. Now, when we're thinking about the HPV-related lesions, it's also helpful to know the exact location that we're thinking about. And so if the endoscopist or the surgeon who's providing the sample can give a better or more full description of where the tumor is relative to the dentate line, relative to the anal verge, whether it's right within the canal or above or below, and so forth. That can be very helpful in defining which of the various differential considerations we might be more inclined to be looking for. Now, of course, sometimes the masses are large enough that they obscure the landmarks and cross boundaries and so forth. So we understand that it's not always possible to do that. But when you can obtain that data, it's very useful. Thinking then about the HPV-related tumors, we've mentioned the condylomas and so forth, and squamous cell carcinoma, as in other lower anogenital tract areas, is frequently associated with HPV, in fact, in the predominance of cases. But in addition to that, there are several other things to consider in the anus. That includes neuroendocrine carcinomas, which can be HPV related, tend to be high grade and concerning. Adenosquamous carcinoma, which also can be quite aggressive. And then several specific adenocarcinomas, including the one with viloglandular patterns that can quite closely mimic viloglandular lesions of the rectal mucosa. Stratified mucinous intraepithelial lesions also are associated with this, as well as adenoid basal carcinoma and the CYLD mutant cylindroma-like basaloid carcinoma of the anus, which probably has a fair degree of overlap with some of the squamous carcinomas that we, specifically the basaloid subtype. So our particular case was biopsied, and we got this sample here, which you can see is several fragments of fairly uniform, highly cellular tissue, somewhat nested pattern to the process, variable size nests, sort of in a, maybe a insular pattern with nests around it and so forth. But notice that there's some areas where it appears we've got a little bit of palisading towards the periphery of some of these nests. In some areas, you can see that subtle palisaded type of change. Notice we also have quite a brisk mitotic rate here. There's a number of mitoses that can be seen. Some of them are kind of atypical looking, dyskaryotic. And also we have a very uniform cytology, no evidence of keratinization, no prominent nucleoli, and very evenly distributed chromatin. Here again is the peripheral palisaded pattern in this lesion. We don't have any mucinous cystic or adenoid cystic type changes. I think we did see some pigmentation in one area of the lesion. Let's see if I can find that, which raised consideration of a melanocytic lesion. We didn't see much in the way of surface tissue here as well. So it can be a little bit difficult to define whether or not there's a surface element when it's kind of ulcerated and diffuse carcinoma like this. So we made the diagnosis based on the morphology and positive P16 stain that this was a basaloid squamous carcinoma. And this tumor, while occurring in the anal region, certainly is not the most frequent lesion here, nor is it the only area where this tumor can occur. We can see this in the head and neck region, in the esophagus, as well as in the GYN tract, in the cervix, and other areas. This does have a strong correlation with the high-risk HPV subtypes. And significantly, at least in the anus, there's some significant mortality from this disease. This one follow-up study showed 30% had died of their disease at the end of the study within 5 years of follow-up. And a fairly significant percentage also developed local recurrences or metastases if they had not died. Because of the similarity we've mentioned to neuroendocrine carcinoma and melanoma, differentiation from those two significant elements or significant diagnoses is also important. And because of the name, there's oftentimes consideration of whether or not this is a basal cell carcinoma of the skin, which could have a dramatically different prognosis and treatment implications. Now, there are some histologic variants, some patterns that can be seen in this, either predominantly or as part of a mixed component. And that includes the peripheral palisading pattern that we've seen here, a more adenoid cystic-like tumor, perhaps related to that CYDL mutant variety, transitional cell carcinoma-like pattern, as well as a mucinous microcystic, which may be partly related to that adenoid cystic component as well. So be aware of those various other patterns as possible considerations as well. Now, likely as more cases accrue and more molecular genetics are performed on these lesions, we'll see some of these subtypes perhaps be separated off by the specific mutation that may be involved, as has begun to happen with the CYDL mutant pattern. In terms of differentiating this from basal cell carcinoma, which is, I think, an important consideration, we've mentioned some of the things that help you. So first of all, basal cell carcinoma is not an HPV-derived or related disease. And so your P16 stain should be negative. Also, site of origin usually will be perianal skin rather than the mucosal surface of the anal canal. So if you see surrounding adnexal structures and a basaloid pattern, probably basal cell carcinoma, especially if you've got any of the other features like retraction artifacts and so forth. Now, if you do have to go to immunohistochemistry, there are two that can be helpful. BREP4 and BCL2 will be positive in basal cell carcinoma and should be totally negative in basaloid squamous carcinoma of the anal canal. Similarly, SOX2 and P16, as we've mentioned, should be positive in the anal basaloid squamous carcinomas. The atypical mitoses can be quite frequent in these basaloid squamous carcinomas and relatively rare in basal cell carcinoma. Now, one pitfall if you have a spindle cell morphology would be that basaloid squamous cell carcinoma can occasionally express CD117. And so if GIST enters into your differential, that stain may not specifically help you. Going to DOG1 in addition, I think would be prudent in that consideration, or maybe just beginning with DOG1, recognizing this potential pitfall. So those are the key points I wanted to cover with you. Our final sign-out diagnosis on this case is basaloid squamous cell carcinoma, HPV related. And of course, we were a biopsy lesion. We didn't have staging information and so forth on this patient, but we would imagine that a more comprehensive staging should be done to enable proper treatment planning. So we hope you liked this program. If you did, please give us a like. And of course, we welcome you to subscribe so that you'll catch follow-up releases from our channel. And as always, we welcome your feedback or comments either directly or in the comments below. I will point out that access to the digital slide that we've used in this sample for your further study, if you'd like, is available. And the link to that is in the description of the video. It should be available to anyone, member or not, in DPA and DAPA. And so, well, thank you for joining me. And until next time, be well, be wise, be cautious, and we hope to see you again.